don't do anything here. I just go through the slides.
Yeah, just right or left. Yeah, right to advance and then left to go back.
Okay, so this is cancer screening and the value of early detection. And I can't emphasize enough the value of early detection. Early detection will determine health outcome. So it will determine being able to get rid of cancer. If you, regardless of where you have it, regardless of what organ you have it in, if it is detected early, the prognosis is excellent. And I'm sure we all know a lot of people that have had cancer in the past. They had chemo, they may have had surgery, they may have had various things done, and now they're cancer-free, and it's been 10 or 12 years. So it's that early detection is the key to that. Cancer is a disorder at the cellular nature. It's where the cells have changed their anatomy, or their cancer cells are very invasive. A cell has some structural effects to it, and then that can change and become cancer. Sometimes, especially, and I haven't really mentioned it in this talk, especially on a pap smear, you may get a report back that says atypical cells. Atypical cells are basically cells that don't typically look like what a cell does in the cervix. It's the pap smear is a smear of the tip of the cervix. So atypical just means that they don't look like they should look in that area of the body. No cause for alarm, but you do need to watch it because you don't want them to change further to be cancer. Breast cancer screening, mammograms 1 to 2 years. You need to have your mammograms done every 1 to 2 years, whatever your doctor tells you you should have done. For baseline, you need to know the baseline of what's going on. And this goes for all screening. Baseline is what you're looking for. You're looking for how the breast looks today, so that if something comes up next year or the year after, you know how long it's been there. If you have your first mammogram at 50 and something is detected, nobody knows how long it's been there. If you've had a mammogram at 45, 46, you have another one at 48, you have another one at 50, then you know, say at 48, something is there, and it may not even be cancer, it might be just a nodule. You know how long it's been there. Look back on the previous mammogram, and you'll see on the previous one, no, there was nothing there, so you know it's only been there at a particular time frame. Breast cancer is the second most common malignancy worldwide. And death rates are decreasing because of improvements in screening. More people are becoming the big public education push from the departments of health about mammograms, so that people have regular mammograms done. And that's the improvement in screening, that's catching things early, that's being able to treat things early, and there isn't as many deaths from breast cancer. Most people if they're going to present with something, they have presented at the screening mammogram. So they go for the mammogram, they might see a nodule. If they do have a nodule or a little thing that looks suspicious in the breast, it is not always cancer. What they will do for the most part is they will then follow with an ultrasound. Once they see it on the ultrasound, the radiographer will examine it and see if it needs to be biopsied. They may then biopsy it. And once they biopsy it, they'll send it off for testing. It comes back negative or it comes back positive for something. If it comes back negative or positive, they will put a marker in your breast. So you've had a biopsy. It's nothing, it's just a nodule, but it's not cancer, it's not malignant. then they will put a marker in the breast. When they've done the biopsy, they put the marker in so that the next time you go for a mammogram, they see that marker and they're not going to misinterpret something that might be there, but that they have biopsied that came back negative, and they're not going to say, oh, what's this? They know they biopsied, they know it's okay, because they've put the marker in there so they know where it was. People that have a suspicious palpable breast mass should go for diagnostic imaging, which is similar, that's ultrasound. And what may happen is a fine needle biopsy or aspiration or a core needle biopsy. And basically that's the biopsy I was talking about. If that comes back positive for malignancy, then you would go to your breast surgeon, or you may just need chemo, or you may need radiation, or you may need to have that area removed. And that will be determined by usually the surgeon, the breast surgeon. Less than 40, so we're looking at risk. Less than 40 is very low risk. We don't really do mammograms on people under 40 because it's a very low risk, and the mammogram isn't as effective for seeing things. It can be, you can have dense breasts or different reasons why it's not as effective to see things. This, I think, is a misprint. 0 to 40. 49, you can raise your, around 45, 49, thereabouts. You can raise the conversation with your provider and say that maybe you want a mammogram or you don't want a mammogram. It's very much your own preference at that age. 49, that's a misprint. 49 and to 74, screening is suggested. Everybody should actually be having every 1 to 2 years, depending on what the results of your first mammogram is, and your history, your family history. If you have mothers, aunts, grandmothers that have breast cancer, you're looking at probably every year rather than every 2 years. But screening is definitely suggested over 49. And you would have your mammogram done every 1 to 2 years, depending on what your recommendation is. Now, I just want to go back about recommendations are, your doctor has information that recommendations come from clinical research and clinical practice. So you go to your doctor, your normal PCP, your primary care doctor, and they know what the recommendations are. And those recommendations are coming from the Agency of Quality Health and Research, which is a government agency, or the CDC, or all the other, and they pull all the research that's being done, and they take a look at it in detail, they analyze it, and they come up with recommendations. And that's what your doctor is going to go by, what the recommendations are, because those recommendations have been researched and there's an evidence base to it. Now, as well as that, your doctor may say, and recommendations can be, okay, every 1 to 2 years. If there's a significant history of breast cancer, 1 year, or of any cancer, it could be 1 year, every year, every 2 years, depending on what your history is, your family history. A lot is what is. And when you go to the doctor, especially a new doctor for the first time, they will always go in depth into your family history. And that's where recommendations are coming from, but also the doctor's clinical decision-making themselves and what they know of you as a patient, they may recommend more often. Colon and rectal cancer is called colorectal cancer, okay? And the screening for that is colonoscopy. There are other ways, if you don't want to have a colonoscopy, there are other ways of checking. One of the ways is to check blood in the stool, and there may not be any blood. What they're looking for, colorectal cancer screening is a way for the doctor, it's usually a GI doctor, a gastrointestinal doctor, that will do the colonoscopy. They will look at the colon, they look at the rectum for signs of cancer or growths. You could have polyps in there. Now, polyps in themselves, we probably all have some polyps. We may have polyps. Polyps in themselves are okay. They will take a biopsy of the polyps while they're doing the colonoscopy and send those off. Those polyps, depending on how long they're there, maybe when they emerged first as a polyp, they weren't malignant, but we talked about cells on a pap smear earlier on, and these cells in the polyps can change. And that's where the problem happens, is those polyps can change to become cancer. So usually you have a colonoscopy done every 10 years. They find some polyps, they biopsy them, no, they're not malignant. 10 years later, maybe they find polyps and they're still not malignant. They will take biopsies of them and they will send them off. The vast majority of them are negative, but you may have positive cancer present. The screening is your baseline. So 10 years ago, there was no cancer there. In the meantime, you may have had some blood. You may have had blood in the stool. If you notice any blood in your stool, that's something that needs to be reported to the doctor immediately, and they will do a colonoscopy. Now, you may have hemorrhoids, internal hemorrhoids, and that may be all that the blood is, but it will be checked. Okay, so colonoscopies are done on people that have no symptoms and no reason to think that they have cancer. It's a screening. You have no reason to think that there's anything wrong. You can have your colonoscopy done. At baseline, it gives everybody involved in your healthcare, including yourself, a baseline to know when something has emerged. And the goal of the colonoscopy is to find and remove polyps before they become cancer, or to find cancer early before it grows and spreads and causes other problems. Cancer can spread from one organ to another. And that's what's meant when you hear the word metastasize. The cells multiply. They multiply, they go to the colon, they multiply, and then they may go to another organ after that. So I'm not sure, to be honest, what organ the colon cancer goes to, but I know that it usually might go to one or other organ first, and then it can go to other places. You can have cancer in one organ, like for instance, the colon, and it may not go anywhere else. You can have a small amount of cancer in the colon that's caught on colonoscopy. That piece can be removed. You may have chemo, you may have radiation, you could have both, and it's done. You would then have your colonoscopies more often. So your screening colonoscopy is every 10 years, but if they find something, or if they find a cancerous polyp and they just remove that polyp, if that's the only place it's there, then they will recommend colonoscopies more often, because the most important thing then is to watch it. Screening for colorectal cancer can identify pre-malignant lesions. I spoke earlier about atypical cells. Your atypical cells can be, and they can stay atypical for a very long time, but they are pre-malignant. Asymptomatic early stage malignancy has a greater chance of being cured. Okay, so early stage cancer, early detection has a much greater chance of being cured. The average risk, so average risk is just average for everybody. Patient's age, it used to be 50 or over was recommended for a colonoscopy. Now it's 45 or greater, 45 or greater, that's the recommendation. Recommendations can change. As more research is being done, recommendations can change. It's not that you recommend something one time and it stays like that forever. They change. As the research comes in and as people see different things going on with different patients, recommendations can change. Continue to screen for colorectal cancer up to the age of 75. The same goes for breast cancer. For the average risk patient, as long as their life expectancy is 10 years or greater. So if you're 75 and you have other things going on health-wise, and the life expectancy isn't going to be more than 10 years, then they're usually not going to do the screening after 75 years of age. Some of the reason for that is, even if they find something, are they going to do anything about it? Are you going to be able to tolerate chemo? Are you going to be able to tolerate surgery? You know, are your comorbidities so much so that the surgery itself is a risk? Most patients of average risk, the recommendation is every 10 years. You will see here on the slide, patient is lying over on their side. They have it's basically a long tube with a camera at the end of it. You are sedated, what they call conscious sedation. So you're really unaware of what's happening, but you're still not unconscious like you would be for a general surgery. When you go for a colonoscopy, people have said that the worst part of it is the prep, where you have to drink, you know, stuff to empty your bowel 24 hours before, and you have to be fasting from 12 midnight, or at least for 12 hours. And that's so that there's no feces in the bowel, and the doctor doing the colonoscopy can visualize. If there's feces in the bowel, they will not do it. They'll stop, they'll send you home, and you'll have to reschedule. They will not do a colonoscopy if there's any lumpy kind of feces in the bowel. That's why you empty it. You have, by the time you're finished the prep, there's nothing coming out but air and water for the most part. And this is just a picture of where you'd lay on your side and where they'll put the tube in. But you don't, you know it's there, you know what's going on, but it's not, you're sedated to the point of where it's not disturbing. They would have to do that because nobody would be able to do that test on you if you were awake, fully awake. They will recommend that you bring somebody with you. And you go in the morning, they will definitely recommend that you bring somebody, that you call somebody to come and they'll call for you to come and pick you up, or have them there when they think you're going to be finished. They will not let you drive home. If you insist on driving home, I'll tell you now, most of the places that do colonoscopy will call the police, and they will let them know that you're in your car and you're driving under the influence of drugs. They will not let you drive home unattended. You know, you can't drive, you should not drive, because regardless of how awake you feel, you are still driving under the influence of medication, drugs, sedative medication. And if you push and push and push, you know, if they can't talk you out of driving yourself, they will call the police in that area, and they will tell them that you're driving under the influence of drugs, because you are. It's just like driving under the influence of alcohol. Especially for older seniors, because remember, and I spoke about this in a talk before, your absorption of drugs is far greater because of the changes that have taken place in the body. Not so much the absorption as much as the elimination. You're not going to eliminate it as quickly as you would have done when you were younger. So there is going to be a level, and these are high-powered drugs like fentanyl and, you know, Versed and those kind of medications. So that's something to remember, that you have to have somebody with you to take you home, and you have to be fasting the night before, and your bowel has to be empty, because they will not be able to see everything that's going on in there if you have feces in the bowel, and they won't continue with the test. Most people that are of high risk would be people with a family history of colon cancer, maybe a brother, a mother, a father, you know, siblings. They can have a CT of, it's kind of like an X-ray, CAT scan, X-ray every 5 years. They would have the colonoscopy every 10 years. And then in between those 10 years, they would have a CT of the colon every 5 years, or stool testing once a year. That's stool testing. The doctor's office will give it to you. They give it to you in a little tube and a scoop. And when you go to the bathroom, you would just scoop the stool in there, and that can be sent off. And what they're looking for in the stool is blood. They can also have a sigmoidoscopy every 5 to 10 years. A sigmoidoscopy is the lower part of the colon, not the entire colon, but it is the lower part. There's also stool DNA testing every 3 years, but honestly, doctors are not really sure of the best time frame for reporting this test. They're not inclined to do that very much. But with a significant family history, you can have these other tests in between the recommended colonoscopy every 10 years. Prostate cancer. Screening for prostate cancer, again, we're talking about average risk. So the average risk is what the average risk is for the population with no significant history of prostate cancer or no genetic mutations. Screening discussions will start when you're about 50 years of age. Men that are known or likely to carry the BRCA1 or BRCA2 genetic mutations, or Lynch syndrome, which is another genetic mutation, are at increased risk. So they would start having prostate screening done earlier than 50 years of age. The BRCA1 or 2 genetic mutations, we've heard about it. I think the most popular or the most topical one was when Angelina Jolie had a mastectomy, because she carries those genes. Purely patient preference if you want to have a mastectomy or not. 70% of people that have breast cancer do not have the genetic mutation. So that's something to bear in mind, that just because you don't have that genetic mutation does not mean that you're not going to get breast cancer. And this is why your mammograms are so important. The same for prostate cancer. People that are men that are more like that carry that genetic mutation are at increased risk, just like breast cancer. People with the gene are at increased risk. That does not mean that you have to run out and get a mastectomy done, because you can, it's the same way, the screening is the same, early detection doesn't end up always in mastectomy. For other men at higher risk of prostate cancer, Black men, men with a family history of prostate cancer, initiating the discussion of screening with your doctor is recommended at age 40 to 45 years. So you would start that discussion before age 50. Screening for prostate cancer, it's a blood test. You're looking at the prostate specific antigen. I'm sure you've heard the PSA test. Testing alone is the most appropriate test for screening. This blood test, you're measuring the PSA, and that's the most appropriate test for prostate cancer screening. Screening intervals are 1 to 2 years. Again, screening up to 70 years of age, stopping earlier if a patient has other comorbidities that will limit their life expectancy to less than 10 years. And it's if you have other conditions, other underlying comorbidities, maybe you had a significant stroke, maybe you've had an underlying diabetes that's not controlled, underlying hypertension, heart disease that isn't being managed well, or that it's not available to manage it well because it's so extensive. A patient with a normal PSA value should be referred to. With an abnormal value is always, your primary care doctor can't take care of this, so they would refer you not to necessarily an oncologist, they will refer you to a urologist. And the urologist is that person that takes care of everything to do with your urine, your prostate, for men, the penis, that whole area, that scrotal area, your ureters, all of that. They don't do your kidneys, but they do your ureters, your bladder, your prostate, and for further evaluation. Men with a PSA level above 7 per millimeter of blood should be referred without further testing to a neurologist. So if it's greater than 7, the referral is to a neurologist. The primary care doctor cannot manage this, nor should they try. Men with a PSA level between 4 and 7, either at 4 or 6, 4, 5, 6, or 7, can repeat the PSA testing in 6 to 8 weeks. Sometimes there might be false positives. When it's repeated in 6 to 8 weeks and the result is the same, then they get referred to a urologist. PSAs that are greater than 4 also should be referred to a urologist for evaluation. So you're looking at 4 to 7, around about that. Not around about it, 4 and going up. Lung cancer. Lung cancer is the leading cause of cancer-related deaths in the United States. Prevention of lung cancer. Preventing smoking and promoting smoking cessation. If you smoke, stop smoking. It is there's a direct link with smoking and lung cancer. So preventing smoking, stopping smoking will have a much greater impact on reducing lung cancer deaths with screening. It'll have it's better than just screening alone. You need to stop smoking. Lung cancer screening is more recent in the past few years, where the recommendation is a low dose computed tomography, basically a low dose CAT scan. So when you go into a CAT scan, it's always going to be radiation for any CAT scan. CAT scan of the brain, you fall, CAT scan of the brain. Problems with your abdomen, CAT scan of the abdomen. CAT scans are not, sometimes I'm sure people may have gone into the hospital and they didn't do a CAT scan. And you may complain later and you might say, I fell and I hit my head. They've done a full assessment. I fell and I hit my head. They never did a CAT scan on me. They should have done a CAT scan. Every time you do a CAT scan, you're getting exposed to radiation. They will not expose you unnecessarily. So there's often times where you may have fallen and there's no other neurological changes and there's no reason. You may have hit your head, but there's no real neurological changes and there's no indication to do a CAT scan. They won't always recommend that because of the exposure to radiation. Mm-hmm. And exposure to radiation is significant. You know, you don't want to expose yourself if you don't have to. That's why this lung cancer screening is a low dose exposure. It's low radiation. And it has been shown to reduce the morbidity and mortality of the number of deaths from lung cancer. So it's a screening that you can have every year. There is a criteria around the screening. So at-risk patients are adults aged 50 to 80 years of age who are at risk of lung cancer because of smoking. And they're usually the people that need to have this lung screening done. So at least a 20-pack, 20 years smoking history, and are either current smokers or former smokers that have quit within 15 years. So if you quit smoking 10 years ago, you're still a candidate for this lung screening. If you quit smoking 20 or 30 years ago, you don't need to have it done. So even if you quit smoking, you need to have quit smoking 15 years or above to not be at risk of lung cancer. So quitting smoking on its own is not enough. You need to be that 15 years out. And that doesn't mean like 15 years out, if you had an odd one at Christmas, That's still smoking. I haven't smoked for 20 years, but maybe I had an odd one 3 years ago. That's not 15 years. 15 years is full 15 years without a cigarette or a cigar or anything else that you smoke. Screening can be discontinued once the individual has not smoked for 15 years or has a limited life expectancy. Again, the limited life expectancy would be that if your life expectancy isn't greater than 10 years, or if you got to the 15-year mark of not smoking, you can discontinue having the screening done. And this is a picture of your lungs. You can see the black from the smoking and the other nice vessels and everything that you can see in there. You can get, there's 3 lobes in your lung. You can get cancer in any one of those lobes, and cancer in one lobe, you may not get it in the other one, but it will travel there if you don't detect it early enough. I'm only going to say a small amount about ovarian cancer. So ovarian cancer has a high mortality rate because most ovarian cancers are caught in the later stages. At the time of diagnosis is usually a later stage. They're very much asymptomatic. There really isn't an awful lot of detection around them where you'd have symptoms or where you may have, blood that's not menstruation. And almost always ovarian cancer has a family history. So it's more prevalent with a family history, in particular those with the hereditary cancer syndrome. And that is, you're looking at those other gene mutations, genetic diseases, different things like that. And you can see the 2 ovaries here at the side and the uterus in the middle. The pap smear I haven't really mentioned, but the pap smear is for cervical cancer and ultimately travels up into the uterus.
And I have a quick question for ovarian. Is that is the best detection for that just getting yearly pelvic exams from your OBGYN or primary? Your gynecologist. Okay.
Yeah, every woman has a primary care doctor and a gynecologist. Yeah. Especially younger women. It's not as important for older seniors, but it is definitely for younger women. You should have your gynecologist and your primary care doctor. A lot of family practice, so your primary care doctor can be an internal medicine doctor, or they can be a family practice doctor. If they're a family practice doctor, they've had the education that will allow them to see children, pregnant women, and adults. So children are not just pregnant women, but women of childbearing age and adults. Your adult medicine doctor really only has the education to see adult medicine. So that's why, and a lot of times you may not know what the qualifications of the doctor is. So that's why I would say get a gynecologist, have that ongoing as well. Gastric cancer screening. Gastric cancer is the most common cancer worldwide. 2 main gastric cancer screenings are the upper endoscopy and a contrast radiography. Contrast radiography is, we talked about CAT scans and, contrast. There's 2 different kinds of CAT scans. One is one that you just go into the scan machine and they take the picture. The other one is one that you get an injected contrast. Goes into your arm, and then you go for the CAT scan, and it shows up different organs differently. It shows them up in more depth. I want to talk about Helicobacter pylori. It's an infection, and there is a very high risk of gastric cancer incidence when people have had that stomach infection. It's basically a gastric infection that more often than not occurs in the stomach. Routine screening and eradication of H. pylori is the abbreviation for it. When that has been implemented or is being evaluated to decrease the rates of gastric cancer. GERD is one of those, a lot of people are familiar with the word GERD, dyspepsia, indigestion, what's the other one, heartburn. You hear all these names. If you have those kind of problems, you need to see your doctor, mention it to your doctor. They will give you and I'm saying that you have it consistently. They will give you a medication so what happens with that is that there's kind of an erosion around the stomach or around where you would have around the hiatus of here at the top here of the stomach. There's an erosion, like a redness, like what you get even on the outside of your skin. So it gets eroded, it gets inflamed, gets red. You need to have it treated because there is a higher risk of gastric cancer because those cells are inflamed, they're changing, and they can change to being cancerous. The medications that they will give you are things like Zantac or Prevacid, Prilosec. All those kind of medications will reduce that inflammation. So there's less chance of those cells changing. H. pylori, however, is the most common prevalent chronic bacterial infection that's associated with peptic ulcer disease. Peptic ulcer is ulcers of the stomach and the duodenum. Chronic gastritis, gastric adenocarcinoma, and gastric mucosa associated with lymphoid tissue lymphoma. It's an infection, it's treated with antibiotics, and it is often, you don't get rid of it with one antibiotic. You may need to be on antibiotics for 3 or 6 months, depending on how it's reacting. It is, however, a bacterial infection. So be very careful we've all heard in the past stuff about salmonella and chicken. Be very careful with food. Make sure that you prepare your food appropriately and that you cook it enough. And the surfaces you're preparing food on, because this is a bacterial infection that gets into the stomach, and eradication of it will significantly reduce gastric cancer. Active peptic ulcer disease. In active peptic ulcer disease or a history of peptic ulcers, then they would test for H. pylori. And it's a blood test. Or you can have an endoscopy done, which is that an upper GI is also called an endoscopy. It's that upper part of the whole digestive system. Down, the tube goes through your mouth, into the esophagus, all the way into your stomach. It doesn't go into the colon. The colonoscopy goes up to the colon, goes into your stomach and investigates that whole area. And you're under conscious sedation for that too. Bladder cancer screening. In the United States, there's approximately 80,000 new cases per year of bladder cancer and around about 17,000 deaths. Of those 80,000. 80,000 new cases every year, that's a lot of new cases. The majority of bladder cancers, 65%, are diagnosed at an early stage. And they are low-grade, non-muscle invasive tumors with a very low risk of progression. So they can be in the bladder, but they're not necessarily going to come out and invade in the surrounding muscle. They will stay localized in the bladder, and that's what makes them, the prognosis of them, good. Again, it would be chemo, radiation, or different treatments that would be from the urologist usually, or the oncologist, both working together. Screening for bladder cancer includes the urine dipstick for red blood cells. So blood in your urine, hematuria is the other name for it. You're passing urine and you think there may be some blood in it, alert your doctor straight away. You should not have blood in your urine. There should be no reason for you to have blood in your urine. Even younger women that are menstruating, they may think there's blood in the urine. It's okay, go to the doctor, ask them to do that dipstick. If it's your menstruation, they'll find out quickly enough, and it's literally putting a stick into a container of urine. Microscopic analysis of red blood cells. They can do a urine cytology test and urine biomarkers. So it's not, there's the test for the red blood cells. They can send the urine off for red blood cells for cytology, which is a check on the cells that are in the urine, and biomarkers. An increased risk of developing bladder cancer can include exposure to chemical carcinogens, tobacco, occupational and environmental exposures. You've been exposed to a lot of environmental pollution and that sort of thing. Older age and males, for the most part, is who gets bladder cancer. And more seniors are inclined to get bladder cancer. But remember, this chemical exposure, being exposed to chemicals can be really, it's bad for every kind of cancer. And here I just have the ribbons. We have all cancers is a lavender ribbon, appendix cancer, I haven't seen much of that. But anyway, that's an amber colored ribbon. Bladder cancer is marigold, blue and purple. Brain cancer is gray. Breast cancer, pink. Carcinoid cancer, cervical cancer, teal and white. We have them all going down here. Childhood cancer is a gold ribbon. Colon cancer is dark blue. Esophageal cancer, esophageal is up here where your food goes into your mouth and then it goes into the esophagus before it goes down to the stomach. Gallbladder is a Kelly green color. Head and neck, again, we have burgundy and ivory. Hodgkin's lymphoma is violet. Kidney cancer. There's a lot more ribbons now than there used to be. All of the organs, for the most part, are mentioned here. Uterine cancer, thyroid cancer, which I didn't really go into them all. Testicular cancer, stomach cancer is that periwinkle color. Bone cancer and sarcoma is a yellow. Prostate cancer, light blue. Pancreatic cancer. Pancreatic cancer can be quite invasive and it's a much shorter life term than it's very difficult to get rid of pancreatic cancer.
And that's one that's hard to detect early, yes. Typically, right?
Yes. Yeah. Yes. And it becomes very invasive and it can progress very rapidly. Ovarian cancer, multiple myeloma, melanoma, lymphoma, lung cancer is white, liver cancer is an emerald green, and leukemia is orange. A lot of leukemia is seen, not as much in adults, but it can be in adults. Mostly we see it in children, and usually it's the prognosis is good.
Leukemia is cancer of the blood, right? Okay.
Yeah, white cells.
Okay.
Yeah, so I hope you found this of value, but if ever, and recommendations are coming out all the time for screenings.
Mm-hmm.
And they're coming up. The lung cancer screening is a relatively new one. But all of these screenings, these are the screenings, the most common ones for the general population. If you have a family history of cancer, ask your doctor those questions. Oh, my father died of liver cancer. Is there a screen for liver cancer? Can I get this done? Or can I, and a lot of when you go to your doctor, and I think we talked about it in lifestyle changes and, exercise, diet, all of those things are important for cancers. All of them are. A lot of the food that we're eating, we don't know we don't know where it was prepared. We don't know where it's coming from. You hear all this about hormones and beef, hormones trying to fatten up. I mean, we see chickens in the supermarket. I've never seen chickens that size. I don't think any chickens are thin things. But you know, they're going to not as much anymore, but injecting animals or chickens or whatever with antibiotics, all of that is going into your system. Everything in moderation. You know, there's an awful lot to that saying, everything in moderation. And it's just important to stay as healthy as is available to you. And that's why these screenings are important. And you may not like to have a colonoscopy, but it is definitely recommended. And I would encourage everybody that's within the age bracket to have it. To have all the screenings, mammograms the same way, pap smears the same way. And there's a lot of other preventative things. I mean, we see the HPV vaccine coming out now for boys and girls, and that's a big prevention strategy. All right, thank you very much. I hope you enjoyed it, and I hope the information was valuable.
Thank you, Mary.
I know it was short.